Welcome to my channel, Chemo Pharmacology 101. My name is Lisa and I am a board-certified oncology pharmacist. In this video, we will be talking about Linvoseltamab. Its brand name is Lynozyfic. Linvoseltamab is a bispecific T-cell engager. Bispecific T-cell engagers, otherwise known as BiTEs, are medications that act by binding a marker on tumor cells and CD3 positive T cells. By linking them together and allowing the T cell to recognize the tumor, they activate the immune system to destroy tumor cells. In an ideal world, the marker is only present on tumor cells and not normal tissues or healthy tissues, but this is not always the case. The marker that this bispecific T-cell engager targets is BCMA, or B-cell maturation antigen. BCMA is present on multiple myeloma cells. It is also present on some healthy B-cell lineage cells. Linvoseltamab binds to BCMA on the multiple myeloma cells and CD3 positive T cells, which leads to T-cell activation and lysis of the multiple myeloma tumor cells. Linvoseltamab is an intravenous product, and there are two different vial strengths of the same medication. The reason that this is done is because the product needs to be in two different strengths to facilitate the dosing for the step-up dosing. Patients receive low doses at the beginning of therapy and higher doses as they tolerate the lower doses. Linvoseltamab is FDA approved for relapsed or refractory multiple myeloma in patients who have received at least 4 prior lines of therapy, including a proteasome inhibitor, an immunomodulatory agent, and an anti-CD38 monoclonal antibody. It is given as an IV infusion, and the length of the infusion as well as the dose are dependent on where the patient is in the ramp-up schedule and how the patient is tolerating it. Pre-medications are required due to the risk of reactions as well as cytokine release syndrome and infusion-related reactions. Patients should receive acetaminophen and diphenhydramine 30 to 60 minutes before the linvoseltamab dose, and patients should receive the dexamethasone between 1 and 3 hours before the dose. The dexamethasone dose before the first 3 doses should be 40 milligrams IV or equivalent. The first 3 doses of linvoseltamab are administered over 4 hours. On day 1 or the week 1 dose, patients receive step-up dose number 1, which is a 5 milligram dose. If they tolerate that without infusion-related reactions or cytokine release syndrome, they move on to the next dose. As long as the cytokine release syndrome is not higher than grade 3, then they receive the next dose in the step-up schedule. So they move on to day 8, which is step-up dose number 2. If patients tolerate that 25 milligram dose, then they move on to the day 15 dose, which is the first full dose. And that is also infused over 4 hours. It is recommended to hospitalize the patient for 24 hours after the first 2 doses, as the risk of infusion-related reaction or cytokine release syndrome is highest during the first 2 doses. If patients experience infusion-related reactions, it is recommended to stop the infusion and treat the patient's symptoms. It is also recommended to resume the infusion at a rate 50% lower than the previous rate if the patient's infusion reaction was grade 3 or higher. If patients only experience a grade 2 infusion-related reaction, it is not mandatory to reduce the rate when resuming the infusion. However, staff may feel more comfortable doing so, and the infusion must be completed within 6 hours. Premedications can be lowered once the patient tolerates at least 1 full treatment dose. So as you can see here, the dexamethasone dose as long as the patient tolerates at least one dose of 200 milligrams, they can start receiving dexamethasone 10 milligrams IV 1 to 3 hours before the infusion. Pre-medications may be discontinued if patients have no CRS or infusion-related reaction after the first full treatment dose, after which they received or before which they received that lowered dose of pre-medications. Patients should receive their week 4 dose starting 7 days after the day 15 dose. The dose will be 200 milligrams over 1 hour if the patient did not have previous CRS or infusion-related reaction with the prior dose. If the patient does not react to the week 4 dose or have cytokine release syndrome, subsequent infusions can be over 30 minutes. If they did, we maintain that 1 hour infusion rate until they tolerate the dose. Starting at week 14, patients can receive their 200 milligram dose every 2 weeks instead of every 1 week. Starting with week 24, if the patient has achieved at least a very good partial response and received at least 17 of the 200 milligram doses, the patients can be moved to a 200 milligrams on a Q4 week schedule. If patients experience delays between dosing, please refer to the package insert for the most up-to-date recommendations for specific dosing as well as step-up information as necessary. It is expected that Linvoseltamab is metabolized into small peptides by catabolic pathways. And as we mentioned previously in this presentation, we want to make sure to monitor patients for infusion-related reactions. Neurotoxicity is a possibility as well as cytokine release syndrome. Up to 9% of patients can experience infusion-related reactions, and most of these are quite mild. Neurotoxicity, typically lower grade, including confusion or lethargy, can happen in up to 8% of patients. Cytokine release syndrome can happen in up to 46% of patients, but a majority of patients experienced only grade 1 or 2 cytokine release syndrome, so pretty mild symptoms of fever, chills, hypoxia, tachycardia, or hypotension. Only 0.9% of patients did experience grade 3 cytokine release syndrome. Almost 40% of patients react to dose 1, and up to 17% of patients react to dose 2. And then a much smaller percentage react to the subsequent full treatment dosing, which is why patients are only recommended to be hospitalized for those first 2 treatment doses. You can also see increased liver function tests. Sometimes this is in conjunction with cytokine release syndrome, and patients may experience fatigue, infections, musculoskeletal pain, headache, and nausea. It is also recommended that patients receive prophylaxis for pneumocystis, as early in the studies, patients experienced pneumocystis, less than 10%, but not a negligible amount. And so once they instituted pneumocystis prophylaxis for patients, the case count dropped to 0. If patients experience cytokine release syndrome, they may experience decreased cytokine P450 activity. So if patients are on a narrow therapeutic index medication and they're experiencing cytokine release syndrome, we'll want to monitor patients much more closely. Lynozyfic is available only through a REMS program, so prescribers and pharmacies must enroll in the REMS program. This is to acknowledge that patients can have a risk of cytokine release syndrome and ICANS, and patients and caregivers must be counseled on the risk of cytokine release syndrome and ICANS, and patients should be instructed to carry a wallet card stating that they are undergoing treatment with Lynozyfic. And thank you so much for watching today. If you have any questions for me, I will be happy to answer in the comments below.